Hello and welcome to The Big Picture. The deaths of 11 women and nearly 25 others left in a critical condition at a Chhattisgarh sterilization camp organized by the state government has opened up old questions again. These deaths are not isolated and have been happening across the country. Apart from questions about this particular incident itself, there are larger questions like the nature of these camps, the hygiene involved, the competence of the health professionals are obvious ones. There are also questions about the way in which the sterilization campaigns are organized by the government, the targets set, and the way they are sought to be achieved. But the bigger issue which has come back to focus is why is the sterilization campaign so largely women-centric? Why is it that so fewer men, the figures are anywhere between 2 to 5%, go in for sterilization, and the kind of sterilization methods employed? We will discuss all this today with a special panel of guests. I have with me Shailaja Chandra, former Secretary, Ministry of Health and Family Welfare in the Government of India, Dr. Sutapa Neogi, Associate Professor, Indian Institute of Public Health, who is also associated with the Public Health Foundation of India, Jashodhara Dasgupta, Coordinator Sahayog, an NGO, and Rema Nagarajan, Senior Assistant Editor at the Times of India. Welcome to all of you. Shailaja, I would like to come to you first. These campaigns, the whole sterilization strategy as such, it is a Government of India strategy, right? It's the Government of India's strategy which is sought to be implemented by the state governments, right?
Yes.
So it is not that the state governments, respective state governments have their own strategies.
No.
So where has it gone wrong when these kind of deaths take place? I was looking at the figures. Some 1,500 deaths have taken place in sterilization camps in the last 10 years.
You see, the fact is that when you do it in a setting which is not hygienic, which would be obviously what would happen because you make makeshift arrangements, you use a kind of hospital or CHC room which is not sterilized, you use instruments which have not been sterilized, you use the same instruments on another woman, a third woman. So these are things which go on. Sometimes something may go wrong, but it doesn't hit the headlines. Here it has. And it questions the whole, what you were just saying, why are women the target? Now, one must go back to the fact what happens in a village life. The woman produces the child.
No, I don't. Let's. We are jumping the thing. I want you to tell me the entire strategy of the Government of India.
Yes.
How long have they say? Is this a strategy which was employed for a long time?
Very long.
Has there not been any changes to it?
No, because it started in 1951. As you know, during emergency, the male sterilization was given a lot of emphasis. It came back to female sterilization.
Post-emergency.
Post-emergency.
Post-emergency, post the kind of experience which people had.
Yes, yes. Male sterilization was completely
dropped.
It was politically a no-no.
Right.
Then you come to female sterilization. There is the normal tubectomy, which is a major operation. You have the laparoscopic thing, which was done in Chhattisgarh. Then you have a laparotomy, which is done, so it is much, much simpler. Now, as far as this is concerned, all this has been part of the national program for years. The target-free approach was adopted by India in 1994. It was adopted because it was felt that these targets are first a hoax, because people just manufacture figures. More importantly, they do not treat the women with any kind of dignity, respect, or even hygienic concern, what to speak of, exactly what's happened here. So there was a lot of activist pressure. And certainly this was a worldwide requirement. So ICPT was signed and India came to the target-free approach.
What is ICPT?
The International
Conference on Population Development.
It was in Cairo. And India signed that, ratified it. In the beginning, the feeling was that we were very strong on targets. We gave it up entirely. Then
when was the targets given up?
94.
94, okay.
Yeah. But there was no way that you get population stabilization on the front burner. Politically, it's a no-no. It's a very, very low-key program compared to so many other things which happen in rural areas. And the third thing is that the woman is the obvious choice because the unmet demand is there. She doesn't want to have another child or her family does not want to have another child. Now you come to the fact that male sterilization was given up. It revived suddenly under Nitish Kumar in his first term.
In Bihar.
In Bihar. In Jharkhand was doing very well on this. Now they have completely gone back to status quo ante. And again,
as far as male sterilization.
So it's just 1% as it is for the rest of the country. The options, condoms, pills and all, I will come to that when you give me an opportunity.
Let me get Jashodhara in on this. Would you agree with her? How do you look as an activist on the ground, and if you people looking at these issues, these government programs, are there a lot of coercion in this? Why is there no coercion or not even an attempt made? She says that, post-emergency, the male sterilization thing was entirely given up. How do men react to this on the ground?
Let me just first respond to the initial question that you raised. Is that whether such a program is appropriate at all in the context of India or not? And I think we have to come in touch.
A sterilization program,
yes,
you mean?
I think we have to come in touch with the demographic reality of India's population. The sterilization program was appropriate when people had large families and wanted to end their reproductive life. At present, India has an enormous youth population, what we call the demographic momentum. And so these young people do not require sterilization services. What they require is sexuality education, and as soon as they enter into partnerships, they require services and information about spacing methods. Unfortunately, we have been unable to realize this in India, and instead of offering anyone spacing methods, all we do is still tell the ASHA workers, wait until a woman in your village has 2 children and then immediately identify her as a target, that a case that has to be brought into a sterilization camp. I think we're completely out of touch with the demographic reality of India. So the debate is not between female sterilization versus vasectomy. The debate is about what are the appropriate basket of choices that we should be offering the young people who constitute the reproductive population of India today. And I'm sorry that we're totally out of sync with this reality.
That's very interesting what you said. Dr. Neogi, you work for the Public Health Foundation of India. You also teach at the Indian Institute of Public Health. How do you people go about it? Do you agree with Jashodhara that, that we are out of sync? Or do you think that these sterilization campaigns and things are necessary?
See, a lot of debate is actually being, it's happening around the fact whether sterilization camp should be held or organized at all or not. But given the situation in India where it's very difficult to motivate people to come for, one-time, services, people generally prefer to organize the sterilization camps where they can actually, or a large number of people can access the services in one go. So sterilization camps is very difficult to say whether it is good or bad, but this is a way to reach out to a number of people in one go. Now, several incidents have also happened in the past where some mishappenings have occurred because of some faults on the part of the care providers or on the parts of women also. But then I think one has to be very careful when they organize these camps because a lot of quality standards have to be maintained. But the whole issue whether one should target towards vasectomy or one should focus only on women, this actually stems from a larger problem. Whether we focus on vasectomy or tubectomy, this is only a tip of the iceberg. And the larger problem is deep-rooted in the society, which is called the son preference or son syndrome, where for everything we generally tend to target the women.
Okay. So Rema, you have heard the different points of view. As a journalist who have been covering health issues and things like that, you think that what Jashodhara says, looking at it from a different point of view, is that happening at all at the government level, at the official level, at the policy level?
I don't think so. I don't think it's happening enough at all. And I completely agree with Jashodhara. It can't be a complete obsession with sterilization. When we are talking basically about contraception choices.
Right.
And it's amazing that women in this country are not given the number of choices that women, even in much poorer countries, are allowed. India is the only country in the world where we have such a large proportion of our contraception being dependent on sterilization. 65%. That's unprecedented.
Is it because it is the easiest way and the simple way out, one-shot affair, you go and get yourself sterilized and then forget about contraceptions and things like that?
Easier for who?
Easier for the women, easier for the men. I don't know. It may be easier for both men and women. Well, it's probably
easier for the policymakers.
Okay.
I don't think it's that we are talking about easier for the women. look at all the other countries surrounding us. Even South Asia, which is supposed to be among regions in the world which has the highest sterilization of women, even in South Asia, India by far has the largest number of people being sterilized, women being sterilized. It's unprecedented. Nowhere else in the world does this happen. Everywhere else, they have a plethora of choices. They have pills, they have IUDs, they have implants. Why is it that our women are not offered all these choices? Why is it that the government program has a single-minded focus on sterilization? And on top of it, you do it like you're doing it to cattle, that you just take them to a camp and get them all done at one go, like 80 sterilizations being done by one doctor without sterilizing the equipment. Because you think that they are poor, it doesn't matter. It's basically because there's no accountability, nobody is keeping a check on any of these things. And that's unacceptable.
What about the gender thing? What about male? There is no, I mean, as Shailaja pointed out, post-emergency, hot potato, it's a political hot potato typhoon, keep the men out. Is that the approach, attitude?
We are a long way away from emergency. So I think to still keep blaming emergency for everything, yes, I mean, it has left a bad scar on our policy making and on the psyche of the country. But then to say that, hence we will never approach the topic of male sterilization and that we'll never ever try to make any kind of policy around male sterilization, I think is foolish because everyone knows that it's a much simpler process than doing sterilization of women.
Exactly. I mean, would you agree with that? It's a much simpler process, it's much safer and more surer method.
And particularly the non-scalpel one is absolutely, I've watched it being done. It takes 10 minutes and you go back to office.
And start working again.
But I would like to just carry the point that she has made a little forward because according to the UN statistics, which I saw, I may be off, but I'll give you the broad figures. India has almost 70% dependency on female sterilization.
Right.
The IUD percentage is hardly 2%. In China, it is around...
Why?
I'll come to that. IUD is very low. Condom use is just 5% of the total use. 40% of them don't use anything at all. It is an unmet demand and there are many problems with that. Plus, you have this pill which is distributed, the ASHA gives it, but the women don't take it. Maybe they have a reason because people suffer from nausea, they suffer from other things. I had looked into this and found what she's saying is correct. In Sri Lanka, Indonesia, Cambodia, Bangladesh was able to move towards stabilization much before India, and we are nowhere near Bangladesh. Why? They moved to injectables. Injectables are being used in all these countries which I just mentioned. So when I asked everybody, why are we not looking at it, they said, oh, there was a lot of activists who said this is just not acceptable because it leads to cancer. Now, again, I tried to find out that if it leads to cancer, there must be some study. No country is going to be absurd and say there is cancerous propensity and you still give it. So you have a whole body called the Indian Council of Medical Research. They must give a final word and the Health Ministry must form an opinion because it is the choice which is being offered and you can do it in the way that you're doing that large numbers are brought. I don't think it is possible really to build awareness and get people to use anything because the younger population, the girls are being married almost 40% before the age of 18. Boys are being married before 21. Within the first day or two, they conceive. They conceive, and 9 months later you have the child. Then the spacing issue comes. After the first child, you don't even wait, and the second child is born. The mother is anemic and malnourished. The child is already undernourished. The second child comes. She has to breastfeed that child. This is a cycle which must be, it's not just sterilization. Age of marriage is equally important.
Jashodhara, I know you have said what you said earlier, but there must be quite a lot of challenges. As Shailaja points out, it's not easy. You say 40% of the demographic profile is that of young and things. There must be a lot of challenges in educating. It's not so easy to get them to accept. What are the kind of challenges you people face?
No, I don't think there's a challenge in educating young people, and our work with young people's guardians within rural communities have shown that even the guardians believe it's good for young people to know about contraception, and they don't believe that it leads to premarital sex. Within young people, I think we have to understand...
Premarital sex is not an issue.
No,
here.
I'm just saying, I mean, the guardians do not actually object to young people getting sexuality education.
Young means at what age?
I mean, as young as, when the sexual activity actually starts.
So that could be 12, 13
years
old.
In India, there have been studies by the Population Council that have shown that young people as young as 14 are engaging in sexual activity, which is penetrative sex. I mean, conception is easily possible after that. So we do need to educate them. So the guardians don't have objections, even in a place like Uttar Pradesh. But I think there are political hesitations involved in trying to provide comprehensive sexuality education to young people.
We have had problems about that,
Yes, we have had objections.
Some minister will say something.
Yes, the adolescent education program has run into a lot of difficulties several years ago and has been completely blocked. And so India has refused to accept that it has a vast body of young people constituting a majority of the population today. And I also just want to respond to what you said earlier about whether it's easier to get them sterilized. I agree with her that it's really easier for policymakers because both male vasectomy and female sterilization through laparoscopic methods are very provider-centered. They need the highest level skilled providers like, OB-GYN doctors or surgeons to actually conduct. So they're very resource intensive. They are not easier to provide. But perhaps the reason why the government has always wanted to uphold these methods is also because of the control mindset. Let's deal with this once and for all, Let's just prevent women from conceiving or men from conceiving once and for all. It's a kind of control ideology that refuses to give women choices, options, other ways to do things. So it's just one final solution. And I think that's really, really mistaken in today's day and age.
Dr. Neogi? Is that the way it is? And you people as doctors, when you approach people, patients, talk to them, larger groups, is it easy to educate them? Is it easy to tell them? Do they understand? If the choice is between whether a male should have himself sterilized or a female among the couple, is it easier to convince people in these matters?
Yeah, actually, there are certain misbeliefs which are still prevailing in the society. Men also feel that it is very easy to target the females. Secondly, there are certain misconceptions around vasectomy in general. People feel males generally have a belief that they may become weak after the operation.
And the females also.
Also equally share similar views.
Right.
So the males generally feel that they may become weak, they may become impotent, they may have to take rest at home, and for which they feel that women obviously are the easy prey. And moreover, in the system, what my experience goes, we have a large number of health functionaries who are actually females, and they are in touch with the female clients also. On the other hand, the number of people who are there to counsel the male clients are generally neglected, and they're much fewer in number. So we also have to give equal emphasis on the male health workers or some male functionaries who can come in touch with the male clients and then convince them or motivate them to adopt some measures.
So are you trying to say that there are less male professionals or male health workers in the field, the more female health workers, that itself becomes a problem in dealing with men?
Yes.
Rema, have you noticed this kind of a odd situation?
Yes, there is a massive shortage of male health workers. Well, there's a shortage of health personnel per se.
Even after this ASHA and all these things have been adopted?
Yes, all of it. I mean, we are woefully short. If you look at any of the countries which have done really well on health, and it is basically countries which manage to put more people out in the field. They have a lot more health workers, they have a lot more health personnel out there. Ours, forget about doctors, we don't even have enough nurses, we don't have enough health workers. And we always keep talking about doctor shortage. The other thing is, I think, again, we tend to go back to, again, talking about male versus female sterilization, when actually the whole debate has to be about offering women more than just sterilization, offering society more than just sterilization as a means. Why are we talking about sterilization? The word should be contraception.
No, the contraception, sterilization, whatever you want to, whatever is the right word to use. The question is, even the urban women, for instance, we're talking of the rural women with their own myths and with their own misunderstandings of things. It's not easy to educate them. But as far as general women are concerned, is it easy to educate them on the various methods of contraception? Do they have access to it? Will they be able to use it? What are the kinds of problems they face at the family level, at the the relationship level?
There might be a lot of problems, but as far as I have seen, if people are convinced that it's really to their benefit, they know how to go about using things. It's just that, I mean, I think we have a very patronizing attitude when we decide that people don't understand, people can't adopt certain strategies. That's not true anymore. Like Jashodhara is saying, look at the young people today. I mean, they know what they want. But then a lot of these things are not even accessible to them. You don't even offer them. Most of these services are not available in the government system.
Would you agree with that?
We'll take the case of IUCD, the copper tea, the old copper tea. Now you have...
Nobody, I mean, you don't hear of copper tea much. No, there was a lot of ads used to come earlier. Now nobody talks about it.
No, the name has changed. It's called IUCD. You have two kinds. One gives you protection for 3 years. One gives you protection for 10 years. When I was in the Population Stabilization Fund, we tried, at least in a few districts, can we offer this the same way you bring people for cataract surgery, you bring women, screen them, because not everyone can accept this IUD, but put it in because particularly for spacing, so that if they've had a child, they can wait for 2-3 years. The feeling is, number one, that the women will take it out. They're not going to keep it in. They can just pull it out and it's out. The second thing about this IUCD business is you need a certain degree of acceptance by the woman and the man that this is not going to interfere in any way. A little bit of extra bleeding, they will immediately take it out. So I think this is something which many countries have found IUD, which in China, for instance, they use it considerably more than anywhere else. And also in Western countries, people use it if they're not on the pill, women. Now, if we were to look at all the basket of when we say we're offering a basket of contraceptives, yes, Asha may go and give some condoms. The man is not going to use them. He's very often drunk also when he comes home. You offer pills. If she has nausea for 1 month, she's not going to take it. You go back to the traditional method, it fails. It's not something which you can depend on. You go back to implant, we don't even talk about it. It's considered to be absolutely carcinogenic. If it is, then the government should say it is carcinogenic and we're not going to touch this subject. Injectables. Sterilization should be the very last route, not the first. Should not be dominant. And as far as male vasectomy is concerned, I know that when I wrote an article on this, maybe 3 years ago, a police commissioner in his comments wrote back, I have had this, it does nothing to your, virility and your... Now, if we had role models like that, who would say this?
No, which again goes back to the question of education which you're talking about. Why is it? I mean, I'm sure there are a lot of people involved in this kind of education. Government itself must be involved in this. Why is it that we are not able to reach? What are the challenges there in reaching to the people?
I'm interrupting, but I really think it is not a political priority.
It's not a political priority.
I think
so
we have
somebody needs to take up this campaign.
Yes.
Because population is no more an issue. We don't talk about it.
We talk about demographic dividend, but what is the use if your children are being born and are dying before the age of 5?
Absolutely. Yes, Jashodhara.
No, I think we have to also kind of realize that overall we are under-resourcing the entire public health system. We are moving it into the direction of a privatized insurance-based system. As the public health systems gets weaker, we have 90% of our medically qualified doctors in the private health system. They are not there, which is why we have only 10% doctors available, and therefore mass-based approaches like camps in unsanitary conditions are okay for the health system, to inflict on poor women. So it's an average of 4 to 5 minutes per woman for a laparoscopic sterilization. When we're talking about the ASHA workers, we had a study recently done in different states of India. For example, in Uttar Pradesh, we interviewed women and we found that the ASHA workers never told them about any other method except sterilization. And that's because of targets being imposed on them from the district and from the block. And the district officials admitted that even today, 20 years after India has allegedly abjured family planning targets, they are given under the table. Performance is measured on that. And so the district officials, some said we have 450, some said they have even more than 1,000 sterilizations to perform as a target.
In a month?
In a year.
In a year.
Yeah.
Okay. Dr. Neogi?
Yeah.
you know, all said and done, I was looking at some of the figures, that as far as the birth rates are concerned, it has come down quite impressively, at least by about 50% in the last few decades. There has been certain success as far as the controlling the population is concerned, but you think how did that happen?
No, the birth rate has definitely come down because of, I think, the attributable factor could be overall development and much more awareness among people that they have to limit the family size. So this is, I think, the key. And with more education and in the recent years to come, I think the population is even to grow, I mean, at a much slower pace, and things will improve, but then it's a matter of time. And obviously, we have to take care of this family planning aspect as a priority, as a national priority, as a state priority. And the health workers and other functionaries are actually in the field, I mean, providing such services, but somehow they have to be oriented even further, that their job is not only to target at the number of tubectomies or vasectomies, but they equally have to promote the temporary methods of contraception.
So, Rema, you know, all said and done, as the same question which I'm asking, 5.7% children per woman in the mid-60s, it has come down to 2.7 in 2010 or, you know, in present times.
Well above 3 in the northern states.
That is the point. There are 4 states which are still, which will have this huge population explosion in the kind of, maybe 40 to 45% of the country's population will be in these 4 states. Why is it that nothing is happening in these 4 states? Uttar Pradesh, Rajasthan, Madhya Pradesh, and I think Bihar.
Well, I mean, isn't it quite obvious that these states are also synonymous with very poor public health systems? There is hardly any investment in the public health system. There are no public health personnel there. So obviously these states are bound to do badly because you're not willing to put your money where your mouth is. I mean, you just talk about these schemes. They're hugely underfunded. They're not badly administered. So this is bound to happen.
Is that the problem?
I would like to differ. Uttar Pradesh has already slowed down its growth rate. It is almost moving into a replacement ratio. And so I don't think
we don't hear that. You know, we are hearing the other, actually a completely different and an opposite point.
No, the facts are there. The facts are there with the government data. I'm not giving any NGO data here. The growth rate has slowed significantly for these states. It has happened. Part of it is also because people do not aspire to have very large families anymore, but they do need to have insurance, as she said, against a very poor public health system causing the deaths of their children. So they do need to have at least some children left with them, you know, at the end of the day. But we also need to understand the issue of demographic momentum, and that is because the earlier generation was quite large and therefore produced large numbers of children who are now in the reproductive age. So for another few years, we will still see the population in actual numbers growing. But that doesn't mean that the rate of growth is the same. The rate of growth has significantly slowed, not just in all the states of India, but also in these states like Uttar Pradesh. And I know because I've been working there for the last 27 years. It has slowed down. And this is a bogey that we keep scaring ourselves with, saying that, oh, the numbers are exploding. The word population explosion is always used. Population momentum is never used, which is like a large goods train trying to put the brakes.
No,
it doesn't stop at once.
I would love to believe what you're trying to say, but the Planning Commission, it's the Planning Commission number. Planning Commission says that UP, Rajasthan, Bihar, Madhya Pradesh will alone account for 44% of the expected addition of 370 million people to India's population between now and 2026.
That's
so that is the challenge. Shailaja, the challenge lies in these states.
Certainly, and I think concentrated attention has been given for the last, I think, about 8 years. The Empowered Action Group states they are called. There are about 6 of them. Jharkhand, Chhattisgarh are also included in that. So there is a focused attention, but it comes back to not just family planning. It's a question of age of marriage. It's also a question of the health of the mother. Because if you have a 2-year gap, infant mortality will come down immediately by 50%. These are all related. They're not just a question of contraception.
Okay. I think we're completely... No, sorry. Very quickly. We completely ran out of time. Very quickly.
I just want to add that when you say there are all these young people, these millions who are going to be added to the population, let's remember they are young people. They don't need sterilization.
They need education. Okay, I think on that note, we need to end. It's completely run out of time, but this is a debate which doesn't normally happen much on Indian media, but as all my panelists say that, population is something which is not on the priority list of the governments or the policymakers. Hopefully, we'll find that after these kind of tragedies, the issue of population becomes an important issue. Thanks to all my guests, Shailaja, Chandra, Jashodhara, Rema, Nagarajan, and Dr. Neogi. Please keep watching. We'll come back with another issue on the big picture same time tomorrow.